All right, welcome back to this is third sessions of the day, the last session of today, but of course not least, we still have another session tomorrow and the following week and the following week after. These sessions we will talk about, hi everyone already here, about perioperative medicine, and the chairperson of these sessions will be Dr. Arif Marsaban. I think everybody already knows Dr. Arif. He's a well-known anesthesiologist in the field of perioperative care. And we have four speakers of today, well-known speakers. We have Dr. William Fawcett from the UK. Hi. We have Professor Narinder Rawal. Hi. And Dr. Rolf Rossaint and Dr. Hara from India. Thank you very much for staying with us, coming for Indo Anesthesia in a different kind of meeting, but hopefully next year we can meet up again. So without further ado, I would like to give the spotlight to Dr. Arif. You may start the session.
Okay, thank you, Dr. Krisha. Good afternoon, everybody from Indonesia and maybe from the other parts of the world. Good morning and good afternoon. My name is Dr. Arif Marsaban. I'm from the Department of Anesthesiology and Intensive Therapy, University of Indonesia, Dr. Cipto Mangunkusumo General Hospital. I will be the chairperson for this session, Perioperative Medicine. We have here four distinguished speakers, and as they're focused in areas, but in other fields, although there will be a presentation in the perioperative medicine. Without any further overdue, because we have four speakers and a tight schedule, I would like to invite Dr. William Fawcett. He is the Vice President Association of Anesthetists, Royal Surrey County Hospital, Guildford, UK, and an honorary senior lecturer, University College London, UK. As you can see, the topic is a great achievement to date, but more still required. So please, your time is yours, Dr. William.
Hello, and good morning. I hope that you can see my slides and hear me.
Yes.
Yes, good. Good.
Clear.
Thank you. Good. Well, I'd like to just take this opportunity to say thank you for the kind invitation. And as you've kindly said, I'm just going to talk about enhanced recovery after surgery, what we've achieved so far and what we still need to achieve. I have a few disclosures. Really only the top one is of importance, which is that I'm executive committee member and website editor of the EOS Society. So whereabouts has EOS come in the last 25 years or so? Well, as you'll be aware, it was first described in the 1990s. Interestingly, it was first described for cardiac surgery, but it really was popularized by Henrik Kellett's group in Denmark and has been known under a series of names such as accelerated recovery, but enhanced recovery after surgery is the title by which we really know and understand it. There are many societies worldwide. So, for instance, in the UK, where I'm from, there's an ERAS UK chapter, but there are many other countries and continents that have their own enhanced recovery after surgery chapters, and there were spin-offs as well. So, for instance, in the United States, that there are sister organisations as well, and we were very pleased at the end of last year to celebrate our 10th anniversary. So, what has been our achievement so far? Well, we've achieved spread in every continent. We've had over 4,000 publications to date, and we've got an increasing body of evidence which would imply that patients have a faster recovery with fewer complications. They may even live longer, and all at a reduced cost. So if we look at what the ERAS Society was like over 10 years ago, there were just a few centres in Northern and Southern Europe. And then over the next few years, it's spread to Canada and the Americas and Australasia and South Africa and Asia as well. And this is pretty much the situation where we are now. So we've got 250 units in over 25 countries. As I say, we've had a large array of publications, and we've also produced guidelines for a huge number of specialties, currently of 19. And we know that these are well accessed and well cited, and we've had more than 700,000 downloads. And we also published a paper a couple of years ago trying to encourage people to have a fixed framework so that we're all, if you will, comparing like with like. The publications, certainly from guidelines, we use the well-known Delphi process, and another key area is the audit area, because we clearly, without collecting good contemporaneous data, it's very difficult to assess progress. So what is it that we need to have a good team? Well, having the team is really the key area. And as I'm sure we all know, we clearly need a surgeon and an anaesthetist, but we need someone who will coordinate, and we need a number of other professionals such as nurses and physiotherapies and dietitians. And we also need to engage our hospital management as well. So if we look at outcomes in enhanced recovery, reduced length of stay was the original area that people targeted, and we now realise that that is, although it's important and has benefits for clinicians and managers, it need not be the only thing that we're interested in. That having been said, patients are generally safer at home than in hospital because there are a number of adverse events that can affect them, such as food and sleep deprivation. They are often immobilized, and they're subject to medication errors. But we published an editorial about 8 or 9 years ago saying that there's a lot more to enhanced recovery than merely reducing the length of stay. And it really gets us to focus on, what do we really mean by recovery? Well, as anaesthetists, we are really focused on the first bit, which is making sure that patients in theatre and immediately afterwards have normal biological and physiological variables. And then the next stage is really their hospital stay, in which we're controlling pain, return of gastrointestinal function, and mobilisation. We have some input into this, but not much. But really the key area is this third phase, in which I think very few anaesthetists would be able to track their patients. And that is really how long it takes for the functional activities and the quality of their life to return back to normal. Excuse me. We know that enhanced recovery programs can significantly reduce hospital stay. We know that there's a reduction in complications, and we know that readmissions are reduced, and there's a shorter stay for those who are admitted. And I would direct you to this review by Ollie Lundqvist in sham surgery. We know that complications are reduced by up to 50%, and there have been a number of studies from Spain called the Power studies. So this Power 1 study showed that if you adhere to ERAS principles, you reduce complications and even reduce mortality. And as I say, this is the first of the studies. The next one, the Power 2, deals with orthopedics. There is some evidence that people on ERAS pathways have an improved survival, and there's probably many reasons for this, such as reduced complications, reduced physiological stress, improved overall health with rehabilitation and nutrition. We know that we can reduce blood transfusion, but possibly one of the areas is for patients who have cancer is that they are fitter sooner to receive other therapies such as chemotherapy and radiotherapy. We know that a properly executed ERAS program can significantly reduce cost, and that's important for us all. And in the paper that I've quoted from Ollie Lundqvist, there's a return on investment of 7.3. So for every dollar you invest, you get 7.3 back. And if you look down some of these specialties here, you can see really impressive savings for the patients. So you might feel that all is fine and it's job done, and we needn't really focus on pushing the boundaries anymore. But unfortunately, that is not the case. And I've just been an author in this article, which is coming out, an editorial in the British Journal of Anesthesia in the next 2 or 3 months, because we still have a significant amount of work that we need to do. The first area is actually ensuring that we implement and adhere to the knowledge that we already have. And there's an area that Henrik Kellett described called the knowing-doing gap. So we know what we should be doing, but we don't always do it. And there can be a number of patient and healthcare professional and institutional barriers that prevent us from doing that. The other thing that we need, as I've alluded to, is having good quality data so that we can not only know what our unit's doing, but can compare to other units. And in this area, the implementation of standardized electronic patient records is extremely important. There's been a lot of research in ERAS, but unfortunately some of it is not really of terribly high quality. And one of the problems is that people are often looking at several interventions at one time, excuse me, which results in a loss of any potential signal in improvement. And really there's a big need for very tightly controlled both patient-specific and procedure-specific interventions. There are lots of units who claim that they're doing ERAS, but when you dig down, you realize that there's only a few areas that they're doing. And we have to ensure that even though hospitals and units may be trained, that does not of itself guarantee better results. We realize that not everyone is following guidelines. As I say, I returned to this area where we need to have data, and we need to have continuous data, as I say, not only to judge our own units, but to compare us to others. Areas that we need to really focus on are frailty. We know that's a major risk factor for complications, and they have a reduced reserve to tolerate these complications. We know that frailty is not the same thing as old age, but we do need to ensure that frailty is picked up and that it is acted on, and we need a multidisciplinary team to do this. For instance, to ensure that the patient's medications are optimized prior to surgery. Another area is optimizing nutrition, and we all know that for some of our patients undergoing gastrointestinal surgery, there's a high prevalence of people being malnourished. We know, in addition to that, that there are significant changes in patients' muscles, which will prevent mobilization and coughing and all the other important activities that rely on good muscle function. And so we need to focus on those, because we know that ERAS pathways reduce the risk in this area. And we're focusing on more and more what patients may benefit beforehand. So, for instance, supplements, and in some areas, immune modulating nutrition can improve outcome. Wherever we can, we give oral supplements, but we may need to give this via tube or as a last resort as a total parenteral nutrition. Anemia is a major risk factor for patients undergoing surgery. We know blood transfusion should be avoided where possible. Intravenous iron is certainly very popular where I work, and has an emerging role. There's some question or not as to whether erythropoietin may also have a role to play. I'm sure that some of you are aware of the PREVENT study, which, although patients who received intravenous iron did not have a superior outcome, there was nevertheless increased hemoglobin and complications in the treatment group. And I'm sure for targeted individuals, intravenous iron prior to surgery will have a major effect on outcome. Finally, other areas, we're looking at rehabilitation, and there's emerging data that is good. Most of us are familiar with the concept of carbohydrate loading, and I think it's important to say at this stage that it is generally not acceptable to substitute official carbohydrate loadings, which contain about 12% carbohydrate, with sports drinks, which are generally unproven and do not have the same effect on insulin. And then for surgeons, there's a big debate as to whether or not mechanical bowel preparation or oral antibiotics are the best way forward for our patients. Sometimes we're criticized for the elements of care. Sometimes there's more than 20, but we generally list all of those so that in some countries where issues are not a standard of care, we ensure that these are all followed. I think the major area that we're focusing on is, interestingly, not the operative area and not even the pre-operative area. It's the post-operative area, which possibly has the greatest impact on optimal recovery. And this includes really quite straightforward issues such as early removal or even avoidance of urinary catheters, getting patients mobilized, and early feeding. Finally, we're also looking at not only elective surgery, but vascular and emergency abdominal surgery and frailty fractures. And there's an evolving role of ERAS principles here too. And lastly, unfortunately, we have to look at COVID, and we really feel that this is an ideal opportunity to roll out ERAS. And there's been a number of areas such as telemedicine, helping to reduce unnecessary hospital visits. But clearly, if our patients can have faster recovery with fewer complications and a reduced length of stay, that is a key area for COVID. So on summary, we know that there are well-recognized benefits of ERAS and we need to build on those. We still have progress for Kellett's goal, which is a pain and risk-free operation. And one of my colleagues says, ERAS does not make bad surgery good, but it does make good surgery optimal, and that's what we're aiming for. So with that, I would like to thank you all for your attention and also for the kind invitation. So thank you.
Thank you, Dr. William Fawcett, for your very interesting presentation, the update about ERAS and what will we do in the future in the ERAS protocol. Before I go to the second speakers, I would like to explain to the participants and also the speakers that questions for the speaker, for the participants should be written down in the Q&A menu in the screen, in the below screen. And for the speakers, you can scroll the questions and answer directly in the Q&A menu. For the first, especially for the first, second, and third speakers, have time to scroll and see the Q&A menu and may answer it directly, written down. For the participant, please ask the question and to whom it's referred to. And for the last speakers, Dr. Hara, probably you have to answer the question live because maybe you have to have no time to scroll the question. And in the last Q&A session, if there is time, we will give a discussion. So the next speaker is Dr. Narinder Rawal. He is the professor in anesthesiology in the Department of Neurosurgery and Intensive Care from Örebro University, Sweden. His topic is perioperative pain management in the ERAS era. Please, the time is yours, Dr. Rawal.
Okay. Can you hear me?
Clear.
Yes.
Clear. Do you see my slides? I'm.
Yes. Yes.
Okay?
Okay. And then put it in the first slide, Rolf.
Yeah. Are we okay?
Yeah, and then put the full screen. The small button at the lower right that I already mentioned. The other one.
Where are we?
Yeah, that one. Yeah, that one.
Is that okay?
Yes, very well.
Okay. So thank you. As you've already noticed, I'm not very great at these technical things, but thank you very much, Susilo, for this excellent initiative, and thank you for the invitation. My topic is pain management with ERAS protocols, and very respectfully, I will have a little different version from the previous speaker. I think Dr. Fawcett mentioned some of the challenges. I will be talking a little more about the challenges. And as an anesthesiologist, I get a little bit confused with all the protocols, and I will illustrate some of the problems that we have, and also regarding pain management, some controversial issues related to epidural technique, non-steroidals, etc. And of course, IRAS has been, before I start, I would also like to mention that I do not have any conflict of interest for this publication. So, yes, there's no question that IRAS has become very, very popular. There are many, many IRAS societies, and there is very good evidence that the length of hospitalization has gone down, and the risk of complications is reduced too. But my message is that hospitalization times have been going down with or without IRAS protocols. And you only have to look at ambulatory surgery setup to see that. They have done even better, in my opinion, without all the fancy labels. And so I'll be talking a little bit about the problems with IRAS and then talk about the analgesia techniques. So I will be talking, I think it was mentioned earlier that length of hospital stay is not the only parameter that societies look at, but the reality is if you look at the literature, it's focused almost exclusively on length of stay. And of course, we all want to reduce costs, and length of stay in the hospital is a major factor for increased costs. So that is fine. But also, in my opinion, the protocols are very confusing and they are very variable, sometimes complex, some issues contradictory, and also very, very difficult to implement. And also, as was mentioned a little bit, if you look at the literature, the quality of the literature is not terribly impressive. So again, not enough emphasis on what is important to the patient. What is the patient-related outcome measures have not been studied to any great extent. Too much emphasis on length of stay. And also the role of analgesia techniques, as I said, and I'll get back to that, a lot of talk about multimodal analgesia. We all want to avoid opioids, but it is not as simple as it sounds. I'll get back to that. So yes, very, very popular all over the world. And these are IRAS protocols for all these kinds of surgeries. And societies all over. So that is fine. And so I will concentrate mainly on colorectal surgery. There are protocols for all kinds of surgery. I will concentrate on colorectal because that seems to be the best documented, if you like. And so these are some of the interventions recommended for IRAS protocols. And the ones that are shown in green or turquoise green are the controversial ones. So about preoperative feeding, no bowel preparation, the American Society of IRAS says, yes, we have to do it. The European Society says, no, it is not necessary. Problems with goal-directed fluids, epidural analgesia, etc. So there are several of these issues which are controversial, sometimes even contradictory. And also, it's almost 25 years, as we were told, that we've had IRAS. So it's not a new concept. And still, there are so many components, we still don't know which are the essential components and which are the non-essential components. And more recent literature tells us, instead of reducing components, we want to have, and also mentioned by the previous speaker about frailty and giving steroids and other stuff, even more components are being added. I want to remind you that I'm still talking only about colorectal surgery most of the time. So poor compliance is a big problem, and also the comparator, because most of the literature says, oh, we introduced IRAS protocols and then the length of stay has gone down, and we have been comparing with traditional care. And it is very unclear what is traditional care, because it is not poorly defined. It is not static. Traditional care has also evolved over time. And even in so-called traditional care or modern traditional care, they also use multimodal analgesia, also don't want to have tubes and catheters, and also want to mobilize the patients early. So it's no real difference between that. And as I said, the length of stay, hospital stay is going down with or without IRAS protocols. So I think there has been too much made about the benefits of ERAS protocols. I'll quickly show 4 or 5 quick slides. And also I want to emphasize that I will be talking only, mostly showing almost all my slides are about systematic reviews and meta-analysis. I am not showing individual studies because, as somebody said, individual studies are like reading the Bible. You can find whatever you're looking for. So I'm sticking to systematic reviews and meta-analysis. And so, sorry, this meta-analysis says compliance is a big problem. Here, for example, about obesity studies. Just look at, and they have, look at that, that's what I mean by not very good quality literature. So to be included, you have to have more than 4 out of 20 elements. So if you have more than 4, then you're included in the study. And then look at the elements. They should have 20, but in those 11 studies, it is 8 elements, 6, 4, 4, 15, etc. So it's very difficult to draw any meaningful conclusions, and their conclusion is the length of hospital stay has been reduced, which we know. Here, another study, another meta-analysis looking at 14 studies. No study used all the 19 ERAS modalities. Again, showing a length of hospital stay 2 to 13 days. What does it mean? 2 days to 13 days. It's all very confusing. And also I am not familiar, and I would like to hear from Dr. Fawcett afterwards when we have discussion. I have not seen any study which includes all the recommended modalities. Hardly any studies. So I think we need to know what are essential and what are non-essential elements. Here, looking at 156 studies, 70 different sets of criteria used to indicate discharge readiness. 70 different criteria. Of course, it is confusing for us anesthesiologists and others. Here, another looking at post-operative ileus, which is one of the important issues in colorectal surgery. The incidence is 1.6 to 68%, 1.5% to 68%. And it depends on how you define. So even today, there is no consensus about what is the definition of post-operative ileus. And of course, then you will get any kind of incidence you are looking for because there is no consensus. Also, I think here, looking at the point I was making earlier about too much focus on length of stay and not enough on what is important from the patient perspective. So this meta-analysis is looking at what is reported in the literature. So look here, I don't have the time to go through everything. Only 16 out of 38 studies look at pain. Only 16 out of 30 studies look at mobilization. Only 4 out of 38 studies look at activities of daily living. So yes, they talk about having patient-related outcomes as a focus, but that is not happening in the literature. It's all focused on length of stay. Here from our own country, Sweden, there is 8 hospitals. What they're saying here is they're looking at total hip replacement, knee replacement. Now I'm talking about hip and knee. And what they do is they start ERAS protocols, and then they show, again, the same thing like many other studies, that they have been then possible to reduce the length of stay from 5 days to 3 days. And that sounds impressive, but it's not very impressive if you look at what is happening with the length of stay. And this is a very busy slide. Please look at the last line only. The length of hospital stay after total knee replacement has gone down from 1990 from 10 days to 2.5 days in 2016. So with or without, there is no mention of ERAS protocols. So length of, and you can see in your own institutions, the length of hospitalization has gone down, whether you have ERAS or no ERAS. And also, I want to just make one point. This is a rather nice study. Don't have the time to go into it. And this is a network meta-analysis of all the treatments that you have for total knee replacement, which is very, very painful. And they looked at all the different analgesia techniques and found epidural inferior to almost all other modalities, which may surprise many people. So even going further, so from 5 days to 3 days sounds impressive, but even more impressive is ambulatory surgery because, and this is some years ago, 80,000 patients, and the conclusion is in selected patients, you can do outpatient total hip and total knee surgery. So that is being done on an outpatient basis. ERAS has gone down from 5 to 3 days, and now here you can do with ambulatory surgery with 1 day. So again, not so impressive. And this, in my opinion, has been more impressive. The dark area shows the proportion of surgery performed on outpatient basis. And as you can see, and this is an old slide, I'm sorry, 20 years old, but it shows that the proportion of outpatient surgery has been steadily going up. And in the United States, it's around 70 to 80% of all surgeries. Here in Sweden and in Europe, little less, maybe 50 to 60% of all surgery. And they have been doing all these things over the years without any ERAS protocols and doing more and more complex surgery or ambulatory basis. So it is even shorter length of stay than what ERAS claims. So I think we have to realize that that there is a lot of work to be done. Here, for example, looking at anterior cervical discectomy, major spine surgery performed on ambulatory basis, and the complication rates comparable to those associated with inpatient surgery. So, and here is a list of surgical procedures that are being done on day care basis. Just look at the types of surgeries. And this is from the United States. And I must say the definition of day surgery is different in Europe. If it is overnight stay, that is not day surgery. In the United States, if it is 23 hours admission, it is day surgery. Nevertheless, look at the list of procedures, and it is quite impressive what can be done on day care basis. So I think, to me, I'm more impressed with what they have done in the ambulatory surgery setup as opposed to ERAS. If I'm looking for some inspiration, I would look at what ambulatory surgery centers and others have been doing without the need for all those huge number of people. I've been looking at the literature, and this is not published yet, but this is my opinion. I think ERAS interventions are complex, confusing, sometimes contradictory, and apparently very difficult to implement. In spite of much hype and almost 25 years, the originator, Henrik Kellett, who was referred to, a good friend of mine, he himself says he published a paper very recently saying, I think I have a slide a little later, showing that it looks good from far, but it is far from good. He's very disappointed, very critical. So the originator of the concept is very critical about what has happened so far. And also there are others who go further, who think the whole concept is about enhanced recovery is obsolete because it should be just standard of care. It is traditional practice, as I mentioned earlier, has also evolved over the time. And so this should be traditional practice provided to everybody and not just a selected few. So going to analgesia techniques, one of the advantages of epidural we've heard all these years is excellent analgesia and reduction in postoperative ileus. We know that experimental studies that epidural with local anesthetics is associated with better gastrointestinal motility. However, there are other methods too, IV lidocaine, other methods, and even chewing gum. And so sometimes when I want to provoke some of my colleagues, I ask them, which is better, a thoracic epidural or chewing gum? Fact is, nobody can answer because there are no head-to-head comparative studies. And chewing gum, in fact, is very effective. There are many meta-analyses showing that chewing gum is effective. And in fact, if you read here, this is recommended by the ERAS Society, sham feeding, sugar-free chewing gum, about 10 minutes, 3 times a day, and this is high-quality evidence. So I'll be talking a little bit also about multimodal analgesia. We all talk about multimodal analgesia. The concept is great to use analgesic drugs, non-opioids, which have different mechanisms of action. So we get some kind of potentiating effect or synergistic effect so that we can reduce or eliminate opioids. Very good idea on paper. In reality, your multimodal is different from my. Ask your colleagues, and it's all mixing and matching. And this is a study of almost 800,000 patients in over 300 hospitals in the United States, looking at how multimodal is being used. And as you can see here, almost every patient received opioids, 97%. And the idea is to reduce or eliminate opioids. So yes, we can talk a lot about it, but the reality is we can't do without opioids. And also, I wrote a paper some years ago, and I looked at the literature, and what we do know is if you combine paracetamol and nonsteroidals, then you will get a beneficial effect. But the effect is rather modest, so don't expect miracles. But combining more than 2 drugs, which most of us are doing all the time, we know nothing about that. And so it seems, in my opinion, the benefits of combining other non-opioids are overrated. We have very little literature on side effects, and combining more than 2 drugs, non-opioids, we don't know. There's just no literature about it. Just like ERAS protocols, when you mix too many components, it's very difficult to draw conclusions, what is essential, what is not essential. And also about nonsteroidals, again, there is the meta-analysis, and they are somewhat controversial because there is evidence that there might be anastomosis leakage if you use nonsteroidals. Others say not so important, but you have to be careful, and it is controversial. Nonsteroidals are excellent in orthopedic surgery and other surgeries. I'm talking about colorectal surgery. It is controversial. And also the idea, I am not against the idea of multimodal analgesia. The concept is good. It's just that, in my opinion, we should not be using drugs like gabapentinoids, etc., but maybe using more regional techniques. If your surgeon just infiltrates the wound with local anesthetic, this simple technique, which in my institution we've been using for over 30 years and done many audits, every patient gets wound infiltration. To me, that, along with paracetamol and some other non-opioids, can be a good alternative. So finally, there's something else which has come up, which I don't know too much enough about, but there is some emerging literature showing that ERAS protocol itself may be associated with increased risk of acute kidney injury. So here is this database study showing that ERAS implementation of ERAS protocol is independently associated with an increased risk of post-operative acute kidney injury. So, and this, I think we need to study more. This is a meta-analysis, again, showing that using ERAS protocol itself increases the risk of kidney injury by almost 100%. So I think I'll skip over this one. So what about the guidelines from the societies? We have to realize that these guideline societies are not procedure specific. And this is what was mentioned earlier too, because if you are going to talk about colorectal surgery, there is literature on colorectal surgery, but all these guidelines are one size fits all. And that we have to realize. They do recommend, for example, for open surgery, thoracic epidural is recommended, but not for laparoscopic. And there is increasing evidence that even spinal technique, tap blocks, lidocaine infusions might be better alternative. And here, this is from IRAS, looking at the issue of epidural. There is increasing evidence that epidural, which has been the gold standard in the past and which is supposed to give many benefits, in fact, increasing evidence showing that it could be harmful. So instead of being beneficial, epidural can be harmful. This is IRAS compliance group. Last line, please read. Longer length of stay with epidural analgesia, and also perhaps even sometimes risk of complications. And this is some recommendations from Prospect Group. And we recommend, look at the surgeries on the left side, and we do not recommend epidural at all these days. For most of the surgeries, we do recommend for thoracotomy, but again, paravertebral would be our first choice. We recommend for open liver resection, yes, but TAP would be our first choice. And for spine surgery, perhaps by the surgeon. So the role of epidural has been decreasing in recent years, and it seems that in fact, it can be harmful if we are using epidural. And here, a systematic review of 74 randomized studies showing that spinal analgesia and tap blocks are the most effective for post-operative analgesia, and also perhaps intraperitoneal local anesthetics, not recommending epidural. And here, just very briefly, there are many good regional anesthesia alternatives to epidural. These are all evidence-based. These are all meta-analysis. Paravertebral in thoracic surgery, continuous wound infusions, LIA, periarticular for hip and knee, tap blocks, preperitoneal, spinal analgesia. So many, many good and simple alternatives. Many, in fact, surgeon delivered. And that is very impressive too. So also some other points mentioning that we as anesthesiologists, we have to look at all these things, but some of them, like directed fluid therapy, are controversial. I think I'll skip that. Just to quickly summarize, I think there's been a paradigm shift in the last 20, 30 years. This is, of course, about total knee surgery, very painful. 80s, we used to give general anesthesia and give intramuscular opioids. Later on, PCA, IV opioids. And then we started using neuraxial blocks, epidural, spinal opioids, combined spinal epidural. Then in the 90s, femoral blocks, femoral sciatic block, lumbar plexus, etc. And now we have the local infiltration analgesia, periarticular technique, femoral blocks with adductor canal block, etc., IPEX, so on. So you can see that we've been going more and more peripheral, and this applies also to other surgical procedures. This was something I wrote about some years ago. So I mentioned that this paper that I said I have a slide about, and this is what I mean. This is from Henrik Kahlert, a recent paper, and this is 25 years again. Looking back at the literature, he started the concept, and he looking back, and you can see that he's very disappointed. And I think the title of the paper says it all: good from far, far from good. That is what he thinks about IRAS in its current form. So my last slide, IRAS is associated with reduced length of stay. We all agree that is fine, and reduced morbidity, that is fine too. However, you can have similar benefits even without IRAS. And for me, ambulatory surgery setup is a better model. It is cheaper, and it is saving even more money. After 25 years, still poor protocol adherence, lack of consensus regarding definition, alias, and essential components. Should we use epidural? Should we not use epidural? Fluid therapy, mechanical bowel preparation, carbohydrate loading, non-steroidals. These are all confusing and unclear and contradictory. As regards role of analgesia techniques, we all hate opioids, but we can't do without them. And of course, multimodal is very good. But if you look at the literature, modest benefits, and in my opinion, regional techniques, simple wound infiltration should be the first line in multimodal techniques. Non-steroidals, controversial, risk of anastomosis leakage, acute kidney injury. I have a question mark there. We need to know more about it. Epidural is not recommended according to the guidelines for laparoscopic surgery, and conflicting recommendations for open surgery. My personal opinion is, although I've done a lot of work on it, it was my PhD thesis epidural, but today times have changed, and in my opinion, epidural should not be used. We have many good, simple alternatives like wound infiltration, TAP, intraperitoneal, etc., and for LIA technique for hip replacement, etc. Thank you very much for your attention.
Thank you, Dr. Rawal, for your very interesting presentation. Your presentation seems for us that there are more questions to be answered in the next studies in ERA, in the future studies in ERA. Yeah.
I think the previous speaker and I agree on that.
Thank you, Dr. Rawal. The third speaker, I would remind the participants, if there are any questions, please write down your questions in the Q&A menu. For our third speaker is Dr. Rolf Rossaint. He is the professor and chairman from the Department of Anesthesiology from the RWTH. I'm sorry, I can't pronounce in the German words, from Aachen, Germany. And the topic is, what is the right pressure during anesthesia? Please, Dr. Rossaint, you can give your presentation.
Yeah, thank you very much. So, could you upload my...
Yes, yes, we will play the recording.
Thank you.
Dear Chairman, dear colleagues, it is my pleasure to give again a lecture during this Indoanesthesia Congress. Obviously, I would prefer to be with you in Jakarta, but this year, due to the pandemic situation, it is not possible. So we are doing the next best thing to give a lecture virtually, and I hope that you will enjoy this lecture. So the topic I have this year is, what is the right pressure during anesthesia? Is this really a problem? And if so, what is the right pressure during anesthesia? So let's start with a case report. Here, a 52-year-old man gets vascular surgery. He has as pre-existing conditions arterial hypertension. He is on beta blocker and he is taking ASS. So when the anesthesia is starting, the first thing we can observe is the initial pressure, and clearly he has preoperative hypertonia. Then after the start of anesthesia, the patient is in need of vasopressors due to the drop in the blood pressure. Then after 4 hours, bleeding is starting. It is surgical bleeding. And the hemoglobin level is decreasing. And then we have a phase of about 2 hours with circulatory instability, and at the end, the patient is a little bit delirious, and he's going to the intensive care unit. The next morning, the patient is extubated, he is breathing sufficiently spontaneously, and he is circulatory stable. But he is somnolent, so he is getting a CCT, and there we see a huge stroke in the posterior border of the brain. So clearly, perioperative hypotension may cause a stroke, and this unfortunately happened in this patient. So how often is organ damage due to intraoperative hypertension? And most of the studies are retrospective studies. So one study demonstrating this in the early times of this part of research in 2013, due to the analysis of a huge database with more than 33,000 anesthesias. And in this study, they observed the blood pressure every 2 to 5 minutes. And they defined the primary outcome, the acute kidney injury and the acute myocardial injury, and they had secondary outcomes, cardiac complications. And indeed, they could demonstrate that a high percentage of patients showed postoperative acute kidney injury. It was 7.4%, and 2.3% showed acute myocardial injury. And the blood pressure, which was clearly associated with the increase of acute kidney injury and an increase in acute myocardial injury, was 55 millimeters of mercury. However, we can observe early, a little bit more earlier, already an increase, but significantly, it's clearly with blood pressure of lower than 55 millimeters of mercury. And then it's very important, how long is this blood pressure drop? Is it only a minute, or is it 5 minutes, or 10 minutes, or even longer? And clearly, it can be shown that the time span of blood pressure drop to lower values than 55 is important. So, however, again, we can demonstrate that already short time periods of less than 5 minutes are increasing the odds ratio to receive acute kidney failure, cardiac complications, and myocardial injury. And the longer the period is, the more probably is the occurrence of these complications. A second study is analyzing patients with coronary artery disease and the association with postoperative complication due to intraoperative hypotension. And this was again a retrospective study, and here 955 patients were included in these studies, and these were patients with or at risk of arteriosclerotic disease who underwent non-cardiac surgery. They defined intraoperative hypertonia as systolic arterial pressure of below 90 millimeters of mercury for a period of more than 10 minutes. And the primary outcome parameter was cardiovascular death or myocardial infarction within 30 days after surgery. And clearly they could demonstrate that if no hypotonia occurred, if a patient has no coronary artery disease, there was a probability to have an event-free survival was the highest. If you have no hypotonia but a cardiac disease, the probability of a event-free survival is already a little bit dropped. If you have no cardiac artery disease, but you have hypotonia, then the probability to have an event is increasing, and the highest probability to have not an event-free survival is if we have the situation that you have a cardiac artery disease and during the anesthesia, hypotonia occurs. So clearly, hypotension and cardiac artery disease are independent risk factors for cardiac events, and the perioperative hypotonia has to be detected and treated fast, regardless of the other risk factors. So is mortality really increased due to intraoperative hypotension? Yes, there are some data showing that this is increasing the mortality probability of our patients. Here, a retrospective analysis with non-cardiac surgery of more than 100,000 patients were analyzing, and they analyzed the absolute mean arterial blood pressures, the mean arterial blood pressure variability, and the time-weighted average mean arterial blood pressure. And the outcome was the 30-day mortality in this group of patients. They could clearly demonstrate that the intraoperative blood pressure variability in patients with non-cardiac disease was not clinically importantly related with the 30-day mortality. This is shown in these two pictures, where we have the standard deviation of mean arterial blood pressure and also the absolute rate of variability of mean arterial blood pressure, and there was not a clinically significant 30-day mortality increase with higher SD values of mean arterial blood pressure, or a little bit more variability in the blood pressure. However, the time-weighted average mean arterial blood pressure was very important. So if you have a blood pressure, mean arterial blood pressure of below than 80, then it starts that the mortality probability is increasing in these patients, and it becomes more clear if you have a blood pressure of less than 55 millimeters of mercury, but also if you have a blood pressure of less than 65 millimeters of mercury. So we have to realize that indeed hypotensive mean arterial blood pressures are associated with a 30-day mortality increase. Especially, and this has been shown by the group of Sessler, that if we have a triple low of mean arterial blood pressure of less than 75 millimeters of mercury, a low BIS values at the same time of less than 45, and at the same time a really low minimal alveolar concentration of any gas, then we will have an increase in mortality. And we have already a doubling of mortality if this period of this triple low ranges between 31 to 45 minutes. But if this increases to more than an hour, then we have a fourfold increase of mortality. So this is a very important risk factor. So the occurrence of low mean arterial blood pressure during low MAC fraction combined with low BIS is a strong and highly significant predictor for mortality. So now we realize, yes, intraoperative hypotension is a really big problem for the patient. So now the question occurs, what is the right pressure? And indeed, there are several studies demonstrating what are thresholds of blood pressure. And here in this retrospective analysis, which has been published 2017, they analyzed more than 50,000 non-cardiac patients. They were receiving surgery between 2005 and 2015. The baseline mean arterial blood pressure was 93 plus minus 10 millimeters of mercury, and the baseline mean arterial blood pressure was in this study very well established, because it was the average of all mean arterial blood pressure readings in the 6 months before surgery. So, and then they defined acute kidney injury, they defined myocardial injury after non-cardiac surgery, and they came up with these values. So they first demonstrated the acute kidney injury with absolute MAP thresholds and secondly, with MAP variation from baseline mean arterial blood pressure. And they could clearly demonstrate that if the MAP value is decreasing below 65 millimeters of mercury, then we have an increase in acute kidney injury. And if the difference of mean arterial blood pressure was more than 20%, again, it starts that the kidney injury is increasing. The same could be demonstrated for mean arterial blood pressure. Also here, the threshold values are below 65 millimeters of mercury, or a difference of more than 20% from baseline values. And so the authors clearly stated that mean arterial blood pressure below 65 millimeters of mercury and a mean arterial blood pressure decrease of higher than 20% are associated with acute kidney injury and myocardial injury. And prolonged hypotension is very important. It increases the risk of acute kidney injury and myocardial infarction on every MAP level. So absolute and relative thresholds had comparable ability to discriminate patients with myocardial or kidney injury from those without. And they stated a strategy aimed at maintaining mean arterial blood pressure above 65 millimeters of mercury appears to be as good as one based on the percentage reduction from baseline. And basically, this study was, and also the other available literature, was the reason that the German Society of Anesthesia stated 2017 that we should avoid decreases of blood pressure to a mean arterial blood pressure below 55 to 65 millimeters of mercury, and that we should treat blood pressure drops in order to achieve at least 40 to 50% of the systolic baseline value. However, later on, there are some other studies showing that the blood pressure could also be treated in a different way. So here we have a study showing the preoperative risk and the association between hypotension and postoperative kidney injury, again in a review of major non-surgical, non-cardiac surgical procedures performed in 8 hospitals. And here the cases were stratified into preoperative risk quartiles based upon comorbidities and surgical procedures. They had a deviation group. So from these data, they performed a strategy, and then they had a second group which served as a validation cohort. And the hypotension was defined as the lowest mean arterial pressure range achieved for more than 10 minutes. Ranges were defined as absolute values or as relative values. So, and then again, the incidence of postoperative kidney injury was analyzed. Here in this study, they could show in the derivation cohort that indeed both possibilities, the absolute values as well as the relative values, are significantly associated with the increase in the acute kidney injury. However, the validation group then showed only that the absolute values are significantly increased with acute kidney injury. So we have to take care, at least following this study, the absolute values as a minimum. Very recently, a further study was published. It's a small study, only about 300 patients were included in this randomized controlled studies. These patients received abdominal surgery, intraoperative until 4 hours postoperative. the blood pressures were measured. The general anesthesia was associated very often with neuroaxial analgesia, and the reference blood pressure was resting blood pressure during the preoperative anesthesia consultation. And then they had a standard treatment. It was defined as if the blood pressure, systolic blood pressure, decreased below 80 millimeters of mercury, or the systolic arterial blood pressure decreased below 40% from the reference values. Then they used ephedrine as a continuous as bolus, and later on as a continuous infusion. And then they had the individualized treatment, and here the systolic blood pressure should stay within the 10% range from reference values, and they had a continuous infusion of norepinephrine in order to maintain this blood pressure. And the primary outcome parameter was a composite occurrence of ZIRS and at least one organ system dysfunction during the first week. And the secondary outcome was duration of ICU stay or hospital stay and the all-cause mortality at 30 days after surgery. And clearly it could be shown for the primary outcome parameter that the individualized treatment has a better outcome than the standard treatment. So here we have some evidence that a personalized care, individualized treatment of blood pressure might be better than the standard blood pressure management. However, this is a small study, and we don't have enough prospective randomized studies in order to show this benefit. So what will be the future strategy? I believe it will be the use of machine learning and closed loop, for example, closed loop treatment. And here we have one very small study. It was performed as an RCT, and where they used machine learning derived early warning systems and the appropriate treatment then, and they could demonstrate that indeed the use of machine learning derived early warning system compared with standard care resulted in less intraoperative hypotension. So whether this will clearly be established with the reduction in acute kidney injury, or whether this will be only a reduction in intraoperative hypertension without any reduction in morbidity after surgery, this has to be shown in future studies. So what are the take-home messages? I believe clearly we can state intraoperative hypertension endangers our patients, and the longer and the more extensive the intraoperative hypertension, the more frequent and serious are the complications. The easiest to teach in my eyes is keep the mean arterial blood pressure higher than 65 millimeters of mercury, and the systolic arterial pressure at least up to 40 to 50% of the baseline values. More difficult to teach is the individualized blood pressure management, aiming for a 10% difference from the reference values. But I'm quite sure that in 20 years we will have future strategies, and maybe at that time point we will have machine learning and decision support systems aiming to avoid the reduction to blood pressure drops of more than 10%. Thank you very much for your attention.
Thank you, Dr. Rossaint, for your very informative presentation. It answers all of us the question of how low and how long during the anesthesia. Thank you.
Thank you.
So we go to the fourth and the last speaker, Dr. Hara. He's an emeritus professor, anesthesiologist in anesthesiology and pain medicine from the Fortis Memorial Research Institute, Gurgaon. So the topic is errors in neurosurgery. So this interesting field for those who are doing neurosurgery. Please, Dr. Hara.
Hello.
Yes.
First slide.
Clear.
First slide. Just नहीं first slide नहीं है. Can you hear me? Good.
Yes, very clear.
Yes.
Yes. Good evening, my dear Indonesian friends. This is greetings from my hospital, Fortis Hospital, which is located very close to Delhi and Delhi Airport. And I must pay my great tribute to Dr. Susilo for organizing such a mammoth conference in these challenging times. Thank you, Dr. Susilo, for this gracious invitation. See, Dr. Narinder Rawal, Professor Narinder Rawal, my guru, he has actually talked a lot about cons of ERAS in different types of ERAS protocol in different types of surgery. I think same thing has happened in neurosurgery, though ERAS has become very popular in colorectal, urology, gynecology, and even the cardiac surgery. But it is slowly and steadily gaining little ground in the neurosurgical field. What are the cons of ERAS that I will be discussing later on with different studies? But in India, we are trying to develop ERAS protocol for neurosurgery, and I seek the support of my Indonesian friends so that we can develop ERAS protocol for neurosurgical procedures in Asiatic countries. But I will be discussing both the preoperative, intraoperative, and postoperative, the ideal way of management depending on the evidence provided through our articles. As you know, enhanced recovery after surgery pathways or perioperative care pathways with multiple evidence-based treatment points or protocols which reduce two things. First is surgical stress response and improve the metabolic response to surgery so that the patient satisfaction and early discharge from the hospital occurs. ERAS pathways are delivered by multidisciplinary team, and it is very successful if minimally invasive surgery is carried out. Of course, in neurosurgery, with the advent of different technology, nowadays the neurosurgeons are involved in minimal invasive surgery. And the ERAS protocol has to be start from the preoperative evaluation of the patient, and it must continue in the intraoperative period and postoperative period. In the preoperative period, not only we'll have to counsel the patient, but also their relations, particularly about the alcohol, smoking, CPAP therapy in obstructive sleep apnea, nutritional status of the and about the immunonutrition if need arises. Of course, intraoperatively, particularly in the neurosurgical procedure, about the hyperventilation, use of mannitol or hypertonic saline, how much incision one has to give, and whether the hair has to be removed in that area or the whole head has to be saved, the surgical techniques, and the fluid therapy, pain management, and postoperative nausea, vomiting, postoperative pain management, antithrombotic prophylaxis, and early mobilization. Coming up to the preoperative period, of course, counseling is paramount, because nowadays, once psychic advice and counseling helps a lot, particularly about the smoking and alcohol consumption has to be stopped. Even few days before surgery is of great help. Same thing with the nutrition. And of course, fasting and carbohydrate loading has already been discussed. That we'll be discussing a little. This is a case report I want to share. A 128 kilo patient with obstructive sleep apnea came to us for major spine surgery. And the patient was having, when we checked his arterial blood gases, we found the carbon dioxide was around 65 to 70 millimeter of mercury. So then we discussed this case with our neurosurgeon, and we advised the patient to undergo CPAP therapy preoperatively for 3 days. And we continued that CPAP therapy immediately postoperatively, and the patient had a good recovery, and therefore we advocate in patients with obstructive sleep apnea and obesity to have CPAP therapy in the preoperative period so that it will help in achieving good recovery in the postoperative period. Benzodiazepines, which was considered to be the pre-medicament of choice in neuroanesthesia, has been questioned nowadays because of its producing hypnosis in the postoperative period. And there is no evidence that pre-induction midazolam reduces awareness. And psychic advice and proper counseling goes a long way in providing good pre-medication rather than resorting to any drugs. And 3-pin fixation during neurosurgery, and previously in cervical spine, we used to fix a Gardner-Wells tongue 2-pin before cervical spine surgery, and it induces intense stress. Thereby, there is increase in the pulse rate, increase in the blood pressure, and also there is increase in the BIS. How to prevent that? Of course, plethora of technique like use of beta blocker, Zylocare have been used. Then we thought, why not to use local anesthetic agent at the pin site, wait for 3 minutes, and we carried out a study in 44 patients equally divided into 2 groups. And lo and behold, the patients who received saline or placebo, they had increase in pulse rate, increase in blood pressure, and increase in the BIS levels, which was statistically significant. Whereas the patients who received 2 ml of Zylocare 2% on both pin site, they had more or less, and it remained for 120 seconds. So we always advise local infiltration at the pin site to obtune the pressure response. Hyperventilation is more or less amrit. Amrit means it is the nectar for the neuroanesthetic practice. But whether hyperventilation reduces the brain volume and intracranial pressure was not studied in the human beings. This was a multi-center randomized trial we carried out in 275 patients. 4 centers were involved: London, Ontario group, All India Institute at Delhi, and NIMHANS, Bangalore, and the Hong Kong group. And we found out, and all these patients who received oxygen, nitrous oxide, and isoflurane or propofol anesthesia, and we placed a 20-gauge cannula once the dura is exposed to monitor the intradural pressure or the intracranial pressure. The patients were hyperventilated so as to maintain the PaCO2 level around 25 to 27 millimeter of mercury for 20 minutes. that is the hyperventilation group, and the monitoring parameters like the brain condition, ICP, and the surgeon's reaction to the brain conditions were recorded. Then after 20 minutes again, after 5 minutes, the normal ventilation, that is 37 to 39 millimeter of mercury ICP, the PaCO2 was maintained, and the pressures were monitored. And we found out there was 45% reduction in the brain volume, and the ICP was significantly lower in the hyperventilation group. So hyperventilation is very useful, particularly in the supratentorial mass lesions, and it provides a conducive atmosphere to the neurosurgeons. Despite providing hyperventilation, there may be requirement of the osmotic diuretics. Previously, we used to, soon after anesthesia is established, we used to start mannitol, but nowadays with hyperventilation and good anesthetic protocols, the surgeons usually request for use of mannitol. And this is a study carried out in Seattle by the Arthur Lamb group in 40 patients, randomized controlled double-blind trial, where they used equiosmolar solutions of mannitol and 3% hypertonic saline, 5 ml per kg, and they found out there was no difference in the brain relaxation score. The urine output was high in the mannitol group, and there was lactate level, increase in the lactate level in the CSF in the mannitol group, whereas increased in the sodium level and in the hypertonic saline group. So one can use, but now still date we have been using mannitol. And this is another study, again 39 patients, 20 patients belong to the mannitol group, and 19 patients, 3% same equiosmolar solutions were used. And it was a randomized, double-blind, controlled clinical trial. And they have found out, they monitored the intracranial pressure in both the groups, and they found out that 3% hypertonic saline provided more effective control of the intracranial pressure in comparison to mannitol. But one can use mannitol and hypertonic saline, but we are still using mannitol without any problem. Whether to use sevoflurane or inhalational anesthesia or total intravenous anesthesia for neurosurgical procedure, the debate is going on. And if you find the European group, they favor total intravenous anesthesia, whereas the American and even we in our center and in the Asiatic countries, we favor inhalational anesthesia group. This is a Gaia trial carried out probably in Italy, where 314 adult patients were divided into three groups. One group receiving propofol and remifentanil, the other group receiving remifentanil and sevoflurane, and the another group receiving sevoflurane and fentanyl. And the primary outcome was time to aldolate score of 9 or 10 after extubation. And they found in both propofol and sevoflurane group, particularly while using remifentanil, it was comparable in both the groups. And time to eye opening, that is following discontinuation of the agent or the inhalational agent or the propofol, to the time eye opening or time to extubation, also remained more or less comparable in both the groups, only 2 minutes separation. And this is another European study carried out to find out whether the total intravenous anesthesia is better than the inhalational anesthesia. But in this group, they followed the same protocol, more or less, the Italian group. The primary outcome was Aldrich score of 9 or 10. But in this European study, they monitored the serum the urinary catecholamine and cortisol level in both the groups. And again, 411 patients were studied, and 380 patients were analyzed, and they found the results were more or less comparable between the propofol, the TIVA and the inhalational group. So whether you use TIVA or inhalational agent, there is hardly it matters. I think it is better to use the inhalational, the anesthetic technique where you are very expert. Whether to use sevoflurane and desflurane, this is also another debate which is still continuing. And this is again a study where 120 patients were analyzed comparing two groups, and they've monitored the emergence, extubation, and recovery, and they found out that in the desflurane group, the emergence, extubation, time to extubation, and time to recovery was little faster than the sevoflurane group, but it hardly matters. 3 to 5 minutes or 3 to 6 minutes, it hardly matters in the postoperative period. But rest of the conditions remains comparable. But this is another very good study from Bilota and his colleagues from Italy, and they studied patients with supratentorial regions with morbid obesity. 56 patients were randomized into two groups, desflurane and sevoflurane. The time to extubation was significantly higher in the sevoflurane group in comparison to the desflurane group. However, the time to Aldrich score of 9 was more or less comparable. But in the sevoflurane group, the patients were acidotic and the carbon dioxide tension was higher, for which they were acidotic, which remained from 15 minutes to around 45 to 50 minutes, which was highly significant. This is the carbon dioxide level, which was significantly higher in the sevoflurane group in comparison to the desflurane group. In our setup, I think all over the world, people must be favoring desflurane in patients with morbid obesity. And their results concluded in overweight and obese patients undergoing craniotomy, desflurane-based anesthesia allows earlier postoperative cognitive recovery and reversal to normocapnia and normal pH. We also looked, when I was in All India Institute, because people, it is written in the literature, desflurane increases the cerebral blood flow and increases the blood volume, thereby it increases intracranial pressure, and this should not be used in neuroanesthetic practice. So we carried out a study in 53 patients. Of course, our anesthetic technique was oxygen nitrous oxide, and we used sevoflurane, and 53 patients were equally divided into, not equally, 52 and 51, divided into two groups. And we monitored again, by placing a cannula into the dura subdurally, and we monitored the intracranial pressure, which was transduced. We also observed the brain condition from the surgeon's point of view, And from our point of view, and also we recorded the intracranial pressure, time to emergence, time to recovery, and mini mental status in the postoperative period. And we found out that in the desflurane group, the brain conditions were comparable to the sevoflurane group, and the intracranial pressure were little less in comparison to the sevoflurane group. So one can use desflurane or sevoflurane in the intracranial procedures. This is a recent publication, most recent publication in anesthesiology, 21 probably. I don't know, it will be coming recently, it will be in black and white. Already it is available in the internet. Delayed neurocognitive recovery after surgery is associated with poor outcome. So their main objective, the hypothesis of this Chinese group was total intravenous anesthesia provides better neurocognitive recovery in the postoperative period in comparison to the inhalational agents. So this study was carried out in 546 patients. However, 226 and 221 patients, total intravenous and sevoflurane group were compared, where the primary outcome was found out. In the sevoflurane group, 46 patients, that is 21%, had decline in the neurocognitive function in 5 to 7 days after surgery, whereas it was 17%, hardly 4% difference in the inhalational agent group. But they found out after 1 hour of skin incision, the IL-16, interleukin 16, was higher in those groups where the cognitive function was little delayed. This is a very good study. Usually during intracranial surgery and during the carotid surgery, in the carotid surgery clamping is done, and in the intracranial aneurysm surgery, the clamping is also done, during which the anesthesiologist either they resort to the hypothermia or brain protective strategies, that is thiopentone loading. But this is IRS study, and a subset of patients were studied to find out whether the neurological recovery with hypothermia plus thiopentone overloading during temporary clipping aneurysm surgery, was it helpful in neurological recovery? And they have found out whether you give hypothermia, mild hypothermia, that is 32 to 34 degrees centigrade, or thiobarbiturate or combination, it is of no use. So please don't give any thiopentone or propofol or mild hypothermia during temporary clipping. Planning of early emergence is very important during intracranial surgery, because this is a great stress. It increases the heart rate, blood pressure, the restlessness, and there is increase in the intracranial pressure and cerebral blood volume. To decrease this emergence phenomena, people have used beta blockers, alpha beta blockers, Zylocard, and so many other things. But we thought, our hypothesis was, if you use low dose or low concentration of anesthetic agents, that will be much more useful rather than any other drug, because the emergence phenomena is nothing but it is a painful stimulus. So we studied this in 3 groups, 150 patients equally divided. Propofol loading soon after the dura closure, 3 milligram per kg per hour, and the other group fentanyl 1.5 microgram per kg per hour. The other group is isoflurane 0.2% till the extubation. And we found out that the emergence was faster, that is 4 minutes in the fentanyl group, whereas it was 6 minutes in the propofol group and 5 minutes in the isoflurane group. The pulse and blood pressures were roughly significantly less in the fentanyl group, and we used less amount of the esmolol to control the blood pressure in the fentanyl group. So my recommendation is to prevent this emergence phenomena. Soon after durac closure, one can use 1 mic per kg minimum of fentanyl so that it provides a smooth emergence during extubation. Whether regional is better or GA is better, this debate is also going on. And this is a recent study from the Switzerland group, in which 100 patients were equally divided into 2 groups for spine surgery. Single level or double level discectomies were carried out. The 50 patients received sevoflurane anesthesia, other 50 patients received the spinal anesthesia, and they have found out that the morphine requirement in the intraoperative period and postoperative period was comparable, whereas the visual analog score was significantly lower following spinal anesthesia, and the patient satisfaction was much better, significantly better under spinal anesthesia in comparison to the general anesthesia group. But the patients lying down in the prone position for 1.5 to 2 hours, and in some cases 2.5 to 3 hours, is very challenging for the anesthetist and also for the surgeon, for the patients also. But one can try, and I will share our experience with some case reports. This is a patient 72-year-old male patient who came with severe excruciating pain and little nerve deficit with L4-5 disc, and with the cardiac reserve was very low. He had incomplete right bundle branch block with ejection fraction of 20 to 25%, and cardiac output was 2.2 liters. So we explained the patient, and we explained the surgeons also. We gave paravertebral block on both sides at L4 level. On the right side, we gave under ultrasound guided, and on the left side we gave fluoroscopy guided, and you can see nicely the nerve roots are delineated, and there is paravertebral sprayed of the agent, and we injected 6 ml of 2% xylocaine, and the patient 1.5 hour procedure without, only at during skin incision. Before that we injected locally, and when the surgeon was fiddling around with the nerve root, we injected instilled little xylocaine 1 ml, so that was very helpful. And this is another patient we have published recently in analgesia practice. This is a 35-year-old female with first time trimester pregnancy with Kodai-Kuna syndrome at L5S1 level, disc bulge, and it was IVF. It was a precious baby for the patient. So again, we explained the patient, and the patient agreed for the the regional block, and under paravertebral block on both sides, that is ultrasound guided. You can see the needle, and we injected the in the paravertebral space on both sides. And again, skin incision was also infiltrated with 2% lignocaine, and the patient tolerated well. And in that case also, we used fluoroscopy only twice. And
5 minutes more.
Delivered, and the baby is doing well. And coming over to the fluid therapy, whether restrictive or non-restrictive, this is a famous study from the Australian and New Zealand, and a large number of patients, and they found out that restrictive is not at all good because it challenges the kidney. So you'll have to be very careful. And this is in craniotomy Taiwan study. They have advocated 80 patients undergoing supratentorial tumor. They have advocated that restrictive fluid is not at all good. Rather, you should give fluid adequate enough to maintain the blood flow. And we carried out also, this is my, it was started with restrictive comparison between whether to give saline or plasma light, and they found plasma light is much better, but saline also, the biomarker in the kidney was challenged with saline. But whereas in this study, 90 patients equally divided into 3 groups, we found out that Ringer's lactate, normal saline 50-50 is much better, and there is no hypernatremia and no acidosis. Vomiting is a major problem because it delayed ambulation, reduced food intake, prolonged hospital stay, and vomiting should be prevented at all cost. And ondansetron, granisetron, and nowadays one can use low-dose dexamethasone, which prevents postoperative nausea and vomiting. Same-day surgery has been discussed very nicely by Narinder Rawal. This is a retrospective study, 5-year study, 329 patients from the Toronto group, 198 patients were analyzed. Awake craniotomy was done in 157 patients, and general anesthesia was used in 41 patients, and successful same-day discharge occurred in 175 patients. However, 5 patients, they came for short admission, again admitted within 24 hours because of seizure, confusion, delay, the neurological deterioration, and 6 patients out of 329 had hematoma. So this is a review article, same-day surgery or outpatient surgery for intracranial procedure is developing slowly in the neurosurgical setup. Patient satisfaction, craniotomy, and of course the surgical technique is improving, and will come to that. This is a Chinese article published about the IRAS protocol and craniotomy, and they have found out in 140 patients the early discharge 4 days versus 7. The patients where the IRAS protocol was followed 4 days, in 4 days they were discharged. Enhanced recovery, this is a very recent lumbar spine surgery, 17 evidence-based protocol they followed meticulously. Of course, satisfaction, early discharge was better in the IRAS protocol. However, in the otherwise the rest remains comparable, but large randomized controlled trials have to be carried out. To conclude, yes, it is a emerging scenario in the neuro setup. Let's combine together and we'll take up this slowly, and let us develop a protocol so that we can carry out good studies. And I wish let Almighty provides His blessings so that this endemic is over soon, and we'll be meeting again in 2022, hopefully. Thank you very much.
Thank you, Dr. Haridash, for your very interesting presentation in neurosurgery. So now is the question and answer Q&A session. We only have a limited time. There's one question for Dr. Rawal. You mentioned that the ambulatory surgery has been done, and it's more shorter than the ERAS protocol applied in patients. So what do you define this ambulatory surgery concept? What is your
I think, thank you for the question. I didn't have time to go into details. And of course, we know that the proportion of surgery performed on day-care basis varies considerably in different parts of the world. And in this field, the United States is ahead of other countries. And I think what I was trying to show was, and of course I did mention, and there is meta-analysis showing that complex orthopedic surgery, hip replacement, knee replacement, spine fusion surgery, etc., have all been done on ambulatory basis. And I did mention that the definition of ambulatory basis is different in the United States and in other parts, where in United States, even if it is 23 hours and 59 minutes, it is still day surgery. But nevertheless, so what they have shown is that with proper patient selection, so now we can't have all these complex surgeries like I showed on a routine basis for every patient. But the ERAS people also select their protocols. And so if you have selected patients who have undergone the usual process and looked at what kind of patients you can have with comorbidities, etc. The point I was making was that it is doable also without ERAS protocols. So I'm not so impressed with ERAS protocols because, as I tried to show, for inpatients, the length of stay for certain procedures can vary from 2 to 13 days in colorectal surgery because there's so much confusion and complicated protocols. My point was that the people doing ambulatory surgery in ambulatory centers, particularly in the United States, if you have good patient selection, you can do, because all of this traditional care without ERAS protocols, like minimal invasive surgery, proper evaluation of patients, patient selection, trying to avoid catheters and tubes, using multimodal analgesia, regional techniques, etc., they are there even for those who do not use ERAS protocols. So my point is that if in any institution you'd feel, oh, I'm no good because the whole world is talking about ERAS protocols and in my hospital there is no ERAS protocols, you can look at your own hospital and you will see that your hospitalization times have been going down anyway. What is good with ERAS protocols is, I think what they do is, it is protocolized care. Everybody is on the same page. Like the previous speaker mentioned about the team. There's a team approach, everybody doing together on the same line. That, I think, is a very good concept. So I don't know if I answer your question properly, but my point is ambulatory surgery is different things in different countries and different institutions. But what has been shown is even without ERAS protocols, you can do it.
Thank you, Dr. Rawal. I see that all the questions in the Q&A menu has been answered by the speakers. There's one question here that's in neurosurgery, Dr. Haridash. Well, my question is, what to do when we have a good anesthesia protocol induction or in using mannitol and hyperventilation period? Still not have a relaxed dura. What should we do? Another dose of mannitol or?
Yes, such situation arises very very rarely, particularly with large midline shift tumors. But in those cases, suppose mannitol has not helped us, then we give a small dose of Lasix, furosemide, 10 milligram, and thereby the brain relaxation occurs. And even if that fails, then one can give small dose of thiopentone or propofol. That also at times helps. If suppose everything fails, then we tell the surgeon to open the dura and slowly relieve the pressure by allowing the CSF. But of course, if there is a large tumor and the large basilar top aneurysm and large tumor, the surgeon usually informs us before. So in that case, we put the lumbar drain, and in such situation, you can open the lumbar drain and drain out the CSF 3 ml, 5 ml, and then slowly the brain relaxes. These are the step ladder pattern of treatment one has to carry out during such, if the brain is tense. Have I answered your question?
Yes, thank you.
Thank you.
I think all the questions have been answered. Are there any questions or comments from the participants? And there's another question here. This is the last question, I think. How to use anticonvulsant in neurosurgery according to ERAS? How do you use anticonvulsant?
Hello?
The question is, how do you use anticonvulsant drugs in neurosurgery?
That's a good question. Yes, anticonvulsants, particularly the supratentorial tumors, we use intraoperative anticonvulsants. The patient, whatever the drug the patient is or was under, that we continue in the intraoperative period. Loading dose has to be given. But in posterior fossa surgery, there is no indication at all. Only in supratentorial surgery, we continue the drug. But of course, nowadays, levetiracetam is commonly used.
Thank you, Dr. Yes. Dr. Rawal, do you want to comment?
Well, since we have a couple of minutes, I just wanted to properly answer one question, because I answered in writing, but it was kind of incomplete. And it was about the use of epidural technique. And the point I was making was because the person who asked the question wanted to know, if you don't use epidural, what do you use? And my point was that we have had decades of epidural use, and of course it has been considered in the past as a gold standard, but now increasing evidence that the role of epidural, it is being questioned, and far from being beneficial, a lot of evidence showing that, in fact, it could be harmful, it could even delay mobilization due to motor block, etc. And it's very difficult to manage epidural. You have to do it for 2-3 days post-operatively. And if you look at the cost benefit, it seems that the benefits have been overrated if you really go into the literature, and the cost, even in terms of serious neurological complications, although luckily still rare, but they are not as rare as we thought in the past. And so there have been many good alternatives to epidural, and I just quickly wanted to mention that. I showed it in one of my slides. You have like paravertebral block for thoracic surgery. You have continuous wound infusions for major abdominal surgery. These are comparisons between epidural and other techniques, and these are evidence-based. These are meta-analysis. And you have like pre-peritoneal use in colorectal surgery. You have the TAP blocks, also in abdominal surgery. And also you have the LIA technique, the local infiltration periarticular technique, which is routine in Scandinavian countries and other countries for total hip replacement, total knee replacement, and even a revival of intrathecal morphine when you're doing something during surgery in spinal anesthesia. At that same time, use a homeopathic dose of morphine, preferably 0.1 milligrams of morphine, which can give you a pretty good analgesia for, if you're lucky, up to 20, 24 hours. But these are part of multimodal analgesia, which was my point, that multimodal analgesia, more regional techniques in multimodal analgesia. These are good alternatives to epidural. They are safer, less invasive, and perhaps even less costless.
Thank you, Dr. Rawal. Maybe other speakers want to comment about this. Dr. Michael Fawcett, maybe? About epidural? No?
There are some questions about the deliberate hypotension. Prof. Rossaint. I've seen several questions. Do you mind to elaborate about what's your opinion about the deliberate hypotensive technique?
Yeah, I think this is not scientifically evaluated. We have only very few data on this. These are not very high patient populations involving. So in my opinion, seeing that we are able to cause damage in our patients with blood pressures below 65 millimeters of mercury, especially if this occurs for a period of more than 5 minutes, and then every ongoing 5 minutes, the percentage of patients damaged by this is increasing. We have to be very cautious. So I would always try to keep the blood pressure higher than 65 of mean arterial blood pressure. I would try, if surgical bleeding is occurring and the surgeon is telling me, please decrease for a few minutes the blood pressure, I would decrease it to values not below 55 millimeters of mean arterial blood pressures, and then keep this period as short as possible. So I would be very cautious to propagate this and to propagate this concept of deliberate hypotension.
Can I make a very quick comment? I used to work many years ago. Many years ago in Houston, Texas, and we had very aggressive surgeons who were always looking at the blood pressure, showing all the time and telling us what to do. And they had two operators, one on top where the surgeon could see, and one below the operating table where it was the real blood pressure. So on the top, it showed what the surgeon wanted, but what you really wanted was below the operating table. Maybe you have to think about it.
That's a very good idea.
Can I add one?
Yes.
For Narinder, you didn't listen at all about IV lidocaine, because I'm starting now using that kind of medicine, and seems that it is helpful. Now we are studying for the neurosurgery cases. It's decrease the opioid need, decrease the inhalation also, and seems the blood pressure is very good. Postoperatively also I use IV lidocaine, it is helpful. So almost no need to give opioid postoperatively. Yes. What do you think?
Yes, you are right. And in fact, I very quickly went through it. The ERAS Society, again going back to colorectal surgery, the ERAS Society guidelines do recommend IV lidocaine as part of the analgesia regimen. And so there are also data showing that it reduces the risk of postoperative ileus as good analgesia. The problem is the practical issue of having a continuous infusion going. If you can handle that, that post-operatively, etc. It's very good. And the blood levels have to be kept in mind, but there are no major reports and any local anesthetic toxicity. So I'm sorry I didn't go into details, but yes, it is good in many areas.
Thank you. Arif.
Thank you. I think it's our time is already over schedule, but I see that in our participants there is a distinguished guest, Prof. Andre Van Zunder. Maybe he can give a comment or just closing remarks in this session. Is he still here?
Yes.
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 Prof. Andre, you can start talking if you are.
So unmute your mic, please, Andre. Oh, unlucky.
It's good. It's not only me who has technical problems.
Or Dr. Julia here. I think Dr. Julia actually wants to ask something. Probably one last question from Dr. Julia.
From Turkey.
Okay. Last question.
Also unlucky.
Technical problem?
I think you can wrap up, Arif.
Okay, I think we just close this session. I've seen in the participant, there are more than 500 participants, nearly 600 in the last minutes. So there are very many participants who are very eager to know about ERAS and the perioperative medicine. And there are still questions about ERAS, and there are maybe more future studies in ERAS to complete or to have a more specific outcomes, like Dr. Michael mentioned about the quality of life in the long term. So I close this session. Thank you for all the speakers, all the participants, and Dr. Susila, Dr. Eddie, Dr. Krisha, as the organizer of Indoanesthesia for this webinar meeting. Very interesting, very informative meeting. Thank you. I think we close it.
See you next year.
Keep safe,
Bye.
everybody.
Thank you, Susilo.
Thank you. Maybe
Thanks a
probably
lot.
next year, face to face next year. Thank you, everybody.
Hopefully.
Very much. Very good session.
Thank you.
Well, thank you very much. So I would like again to thank Dr. Arif for moderating these sessions, Prof. Narinder, Prof. Rossaint, wonderful video, also Dr. Bill Fawcett and Dr. Hara. Thank you very much. I think this actually concludes our sessions for today, but do not worry, do not sad, because we have another session tomorrow. We will start at 9 a.m. Yeah, we will start at 9 a.m. We will have some e-posters, some pre-recorded musics, so you all can still enjoy, and then we will start the session. I think in the morning we will have the obstetric anesthesia at 10 a.m.